Hi there, my valued, highly treasured and esteemed viewers and listeners, and welcome back to your channel of choice. My name is Dr. Nath Arwa, and I am a clinical pharmacist by training and by profession, and I am the founder of Progressive Pharmacotherapy Consultants, a premier virtual clinical pharmacy institute for capacity building for healthcare workers. The virtual clinical pharmacy institute with a difference, where patient safety, medication therapy management, and clinical outcomes, optimal clinical outcomes, are very crucial and non-negotiable to us. Here, we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So I humbly urge you to sit back and spare me part of your very precious time to share with you some precious tips which may prove useful in your line of duty. Welcome. Question number 1 reads, Mr. JJM, a 47-year-old man, experiences an asthma exacerbation at home. His measured PEF is 50%. He is able to follow an established asthma action plan and successfully resolve the exacerbation. He returns to baseline. So my question to you is, which of the interventions listed below would be the most appropriate for Mr. JJM? Would you opt to add Theophylline to his regimen? Would you add Prednisone 40 milligrams orally once daily for 5 days? Or would you propose IV Methylprednisolone at a dose of 40 milligrams infused every 6 hours over a 5-day duration? Or would you refer this patient for pulmonology for IL-5 antagonist therapy? I'll give you 10 seconds to choose the correct answer. So I would opt to add 40 milligrams of prednisone taken orally once daily for a 5-day duration. Now, patients who have experienced a severe exacerbation with a PEF less than 60% should be started on an oral corticosteroid treatment. And guidelines state that prednisone at doses of 40 to 50 milligrams per day for 5 days is recommended as the corticosteroid regimen of choice that should be a component of an adult patient's action plan. Now, if the patient was in the accident and emergency department or in an acute care setting, then methylprednisolone administered IV would have been an option. However, since Mr. JJM was able to manage his exacerbation at home, in my opinion, IV medication isn't appropriate at this juncture. Now, Theophylline shouldn't, in my opinion, be initiated without guidance from the clinical team. However, it can be used in severe and controlled asthma after other preferred agents have been optimized. Remember that. Now, referral to pulmonology for IL-5 antagonist therapy isn't the most appropriate recommendation at this time. I would like to remind you that if corticosteroids and asthma regimen optimization don't control a patient's asthma, then additional therapies may be investigated. Now, in patients' written asthma action plans for severe exacerbations with PEF or FEV1 less than 60%, patients should be given a course of oral corticosteroids. That is reported widely in literature, and I would just like to underscore the fact that 40 to 50 milligrams of prednisone per day should be administered orally for 5 to 7 days, depending on the clinician treating, and that is an appropriate regimen for this particular indication. I would like to remind you that tapering of oral corticosteroids isn't necessary unless the treatment exceeds 2-week duration. So for a 5-day course, you don't need to taper the steroids. Let's move to the next slide, please. And the question reads, which of the medications listed below can reduce the incidence of chronic obstructive pulmonary disease exacerbation? Would it be roflumilast, or would it be theophylline, or would it be N-acetylcysteine, or would it be aspirin? I'll give you 10 seconds to choose the correct answer. So both answers A and C are correct. Roflumilast and N-acetylcysteine. Now, mucolytics such as N-acetylcysteine can improve the health status and even reduce the incidences of COPD exacerbation when they are used regularly. Now, roflumilast, on the other hand, can also reduce the incidence of COPD exacerbation requiring corticosteroids in patients with severe or very severe COPD and a history of exacerbations. It is also considered an add-on therapy in such patients, and it's not first-line treatment, and it is not used for acute exacerbations either. So because of the cost, use it for the right indication, please. And I would like to underscore that aspirin doesn't impact morbidity or mortality in COPD patients. Theophylline, on the other hand, was once commonly used in patients with both asthma and COPD. However, it doesn't improve survival in my opinion, and it doesn't reduce the incidence of COPD exacerbation. So just to repeat again, roflumilast is a phosphodiesterase type 4 inhibitor which inhibits breakdown of cyclic AMP, and it also reduces inflammation, and that makes it very useful in the management of such patients. Let's move to the next slide, please. And the question reads, Master PLA, a 7-year-old boy, is initiated on zafilukast, which is a lycotriene antagonist, for the maintenance management of his asthma and his allergies. His mother is present and inquires how she should administer her son's new medication. So my question to you is, which of the following statements would best answer this concerned mother's question? Is it true that he should take it only once daily? Or is it true that he should take it on an empty stomach? Or is it true that he should take it with the largest meal of the day? Or is it true that he should take it when he's having wheezing symptoms, PRN? I'll give you 10 seconds to choose the correct answer. So he should take it on an empty stomach. Now, zafilukast is a leukotriene receptor antagonist that should be taken twice daily, not once a day, on an empty stomach. That means 1 hour before a meal or 2 hours after a meal. And that is majorly to maximize its absorption from the gut. Now, taking zafilukast with food can reduce its absorption or the bioavailability by as much as 40%. That is quoted in literature. And I would like to emphasize that zafilukast should only be used for maintenance and prevention of symptoms related to asthma and not for acute symptoms. So just remember that as you use it to manage your patients. Let's move to the next question, please. And it reads, Mrs. J.R.M., a 28-year-old female, is diagnosed with mild intermittent asthma. She informs your chest physician she has never used any pharmacologic therapy for her asthma. She's treatment naive. Now, due to her occasional wheezing and coughing, she strongly feels that she needs, in her own words, something for the asthma. So my question to you is, which of the therapies listed below would be the most appropriate for JRM now? Would it be combination of fluticasone co-formulated with salmeterol, inhaled twice daily, or would it be 10 milligrams of montelukast taken orally once a day, or would it be PRN salbutamol inhaled at a dose of 1 to 2 puffs up to 4 times daily, or would it be mometasone 200 mics inhaled once a day? I'll give you 10 seconds to choose the correct answer. So C is the correct answer. Salbutamol inhaler, 1 to 2 puffs, inhaled up to 4 times daily when necessary. Now, based on JRM's mild and intermittent symptoms, the initiation of a SABA, short-acting beta agonist, or rescue inhaler is warranted at this stage. Now, most clinicians and recommendations would consider the addition of a low-dose inhaled corticosteroid. Now, in this particular case, salbutamol inhaler is the correct choice for JRM's asthma severity classification. Let's move to the next slide, please. And the question reads, which of the medications listed below is contraindicated in asthmatic patients and those with hyperactive airway disease? Is it the ARB Candesartan, marketed as Atacand? Or is it the S inhibitor Lisinopril, marketed as Prinivil? Or is it the beta blocker Propranolol, marketed as Inderal? Or is it the calcium channel blocker Diltiazem, marketed as Cardizem? I'll give you 10 seconds to choose the correct answer. So Propranolol or Inderal it is. Now, Propranolol, marketed as Inderal, is a non-selective beta blocker. Now, the non-selective beta blockade can block beta-2 mediated bronchodilation, and that may affect many patients with asthma or hyperactive airway disease who need bronchodilation to be maintained or to be controlled. Now, Diltiazem is classified as a non-dihydropyridine calcium channel blocker, while Lisinopril can prevent the breakdown of bradykinin and thus cause an unproductive cough, though it is not commonly known to worsen asthma or cause bronchoconstriction. Now, Candesartan, as I said earlier, is an ARB which does not worsen asthma at all. So all those many words qualify Propranolol as the correct answer. Let's move to the next slide, please. And the question reads, which of the statements below accurately describes the mechanism of action of Mepolizumab, marketed as Nucala? Is it true that it binds to the interleukin 5 receptor? Or is it true that it inhibits inflammatory cells and release of inflammatory mediators? Or is it true that it binds to CYSLT1 receptor? Or is it true that it activates beta-2 adrenergic receptors? I'll give you 10 seconds to choose the correct answer. So it binds to interleukin 5. Now, Mepolizumab is an interleukin 5 antagonist monoclonal antibody, precisely described as IgG1 kappa, and it's indicated for add-on maintenance treatment of patients with severe asthma aged 12 years and above who have an eosinophilic phenotype of asthma, and it is administered subcutaneously once every 4 weeks. So remember that if you opt to ever treat a patient using it. Let's move to the next question, please. And it reads, Miss JPO, a 19-year-old girl newly diagnosed with asthma, receives a prescription for salbutamol metered dose inhaler to be administered as needed for intermittent worsening wheezing. So my question to you is, which of the statements below best describes how salbutamol can treat wheezing associated with hyperactive airway disease? Is it true that it decreases the activity of guanylate cyclase? Or is it true that it increases cyclic AMP mediated reductions in cytosolic calcium concentrations? Or is it true that it increases the interaction between actin and myosin in the terminal bronchioles? Or is it true that it decreases cyclic GMP mediated reduction in cytosolic calcium concentrations? I'll give you 10 seconds to choose the correct answer. So it's true that salbutamol increases cyclic AMP mediated reductions in cytosolic calcium concentration. Now, salbutamol is a beta-2 agonist which can cause an increase in the activity of adenylate, cyclase, which results in an increase in CMP, cyclic AMP, and eventually lowers cytosolic calcium. That's the mechanism by which it relaxes smooth muscles. Now, the reduction in calcium causes less interaction between actin and myosin, thereby resulting in smooth muscle relaxation of the terminal bronchioles. Now, antimuscarinic or anticholinergic bronchodilators increase the activity of guanylate cyclase, resulting in increases of cyclic GMP, and that eventually lowers cytosolic calcium concentration. That's the mechanism by which they also lead to bronchodilation by relaxing the smooth muscles. Now, I would like to emphasize that terminal bronchioles contain smooth muscles and they lack cartilaginous rings that are present in the larger upper airways. And it's the main contributor to the amount of airflow in and out of the alveoli, just for your information. Let's move to the next question, please. And it reads, Mr. Z.A.J., a 69-year-old man, is being discharged home by your chest physician on portable home oxygen for his chronic obstructive pulmonary disease management. My question to you is, which of the statements listed below is the most important teaching point for Mr. Z.A.J. now? Would you emphasize that he keeps the tubing clean? Or would you sensitize him to avoid open flames and stay at least 5 feet away from any source of heat, or would you recommend he stores the oxygen tank horizontally to prevent it from falling over, or would you advise him to apply petroleum jelly to his nares if chafing occurs? I'll give you 10 seconds to choose the correct answer. So I would encourage this gentleman to avoid open flames and to stay at least 5 feet away from any source of heat. Now, avoiding open flames, which may include cigarettes, matches, candles, and other sources of heat, is the most important teaching point to emphasize, since it relates to safety. Now, keeping the tubing clean is important to prevent bacterial growth, but it isn't the most important. Always remember that the oxygen tank should be stored upright in a secure storage device. Avoid making it lie. Now, petroleum jelly would be a no-no. It can be flammable, especially when mixed with oxygen, and its use should be avoided in this category of patients. I would just like to add other teaching points. If, say, a fire occurs, they may include, for example, advising the patient to immediately turn off the tank if it is knocked over and it begins to hiss. It may include, for example, emphasizing that if the regulator breaks, or if it can't be turned off, the patient should remove the tubing and leave the room, and even call the fire department for help or for intervention. And I would also advise such a patient to call the healthcare provider immediately if there is a blue tint to the lips or the fingernails, or if they experience an increased shortness of breath, wheezing, or a change in breathing with oxygen in place, because that could be a mark of deterioration in their health. I would also encourage them to get in touch with their healthcare provider if they experience confusion, restlessness, or even anxiety more than the normal level that they deal with on a daily basis, and even if they experience new onset chest pain. Those are just by the way. Let's move to the next question, please. And it reads, your clinical team is treating an asthmatic patient. So my question to you is, which of the statements listed below best describes the role of long-acting beta-2 agonist bronchodilators in relation to the use of other controller or maintenance medications in asthma, to be specific? Is it true that LABAs should be initiated before the use of an ICS, or is it true that LABAs should be initiated after using an ICS, or is it true that LABAs are only indicated early in the management of asthma, that is in the early stages of asthma, or is it true that LABAs can be used as monotherapy? I'll give you 10 seconds to choose the correct answer. So B is the correct answer. LABAs should be initiated after the using of an inhaled corticosteroid. Now the guidelines state that maintenance therapy with an inhaled corticosteroid should be initiated or instituted first before LABA can be used in the overall management of any case of asthma. In addition, LABA should be stopped before ever stopping patient on an ICS for chronic asthma management. Now the rationale is that it has to do with the ICSs being used to prevent asthma exacerbation or attacks whereas the LABAs don't treat the underlying cause. They only relieve symptoms of the underlying cause. That's why the ICSs play a major role and the LABAs can be add-on therapy. Let's move to the next question, please. And it reads, Master PBO, a 13-year-old boy, has been on beclomethasone, abbreviated as QVAR, inhaler which he administers twice daily for the past 9 years. His father inquires whether there is an option that can be administered once daily for his son's asthma. Now, as the clinical pharmacist on call at the chest clinic today, which of the products listed below would you recommend for maintenance treatment of asthma for PBO today? Would you settle for Spiriva Handiheller, or Spiriva Respimat, or Daliresp, or Tardoza Press Air? I'll give you 10 seconds to choose the correct answer. So B would be the correct answer. Tiotropium bromide, marketed as Spiriva Respimat, is an orally inhaled anticholinergic agent which is indicated for the maintenance treatment of asthma in patients 12 years or older, and it is administered once daily. It's an OD option. Now, the Spiriva Handiheller is an orally inhaled anticholinergic which is indicated for long-term, once daily maintenance treatment of bronchospasms associated with chronic obstructive pulmonary disease, and it can also be used for the reduction of COPD exacerbations. So it wouldn't be the optimal choice in this case. And then roflumilast, which is marketed as Daliresp, is a phosphodiesterase type 4 inhibitor that is recommended for oral once daily use to reduce the risks of chronic obstructive pulmonary disease exacerbations. So that also makes alternative C wrong. And then aclidinium, which is marketed as Tardoza Press Air, is an anticholinergic which is recommended to be inhaled twice daily for long-term maintenance treatment of bronchospasms associated with chronic obstructive pulmonary disease. So that makes D wrong as well. Let's move to the next question, please. And it reads, Mr. NAK, a 27-year-old man, is due for discharge from your hospital after his second acute asthma exacerbation in the last 1 year. He currently administers fluticasone propionate at a dose of co-formulated salmeterol twice daily with prorenata budesonide co-formulated for formoterol inhalation. He confirms compliance with his regimen, and following the workup done at the clinic, the immunology panel revealed an elevated total serum IgE of 125 units per ml. So my question to you is, which of the interventions listed below would be the most appropriate for NAK now? Would you choose to add Mepolizumab administered subcutaneously once every 4 weeks, or would you choose to add Omalizumab administered every 2 to 4 weeks, or would you choose to add oral daily prednisone, or is it true that no additional medication is needed at this time? I'll give you 10 seconds to choose the correct answer. I would choose to add Mepolizumab every 2 to 4 weeks. Now, for patients with high total serum IgE and severe uncontrolled asthma, already taking high dose inhaled corticosteroids and LABA, Mepolizumab is an appropriate add-on therapy according to the GINA guideline for asthma management and prevention. I would recommend you read the guideline for your revision. Now, oral corticosteroid therapy can also be an option for patients with severe uncontrolled asthma. However, it isn't recommended as first-line add-on therapy, especially on a daily basis without an end, like in option C. Now, I would like to add that patients should be screened for immunologic factors contributing to the asthma, such as IgE, IL-5 and IL-4, and specific targeted therapy needs to be initiated after you've done your workup. I would just like to remind you that Mepolizumab is a treatment option for patients with an anti-IL-5 mediated asthma. Now, since this patient has a high total serum IgE levels, Mepolizumab isn't the best option among those that are listed for his particular case. Now, this patient requires modification of his pharmacotherapeutic plan since a modifiable cause has been identified after the workup. Now, patients with severe uncontrolled asthma that have an identified immunologic component such as an anti-IgE, IL-5 or IL-4 have numerous options for pharmacotherapeutic intervention. And I would like to add that Mepolizumab should be included as add-on therapy for patients with severe uncontrolled asthma with high levels of IgE in the serum. It carries a black box warning of anaphylaxis, which can occur as early as after the first dose of Mepolizumab, but it has also occurred beyond 1 year after beginning regularly administered treatment. So be very careful when introducing a patient on Mepolizumab. There could be anaphylaxis that could worsen the asthma control. Let's move to the next question, please. The next question reads, PJR, a 65-year-old patient, presents to your chest clinic with the chief complaint of shortness of breath, productive cough, and increased virulent sputum production. Your chest physician diagnoses chronic obstructive pulmonary disease exacerbation and determines that outpatient management will suffice. So my question to you is, which of the regimens listed below would be the most appropriate for outpatient management of this COPD exacerbation? Would you settle for Salbutamol metered-dose inhaler alongside oral Prednisone, or would you settle for Salbutamol metered-dose inhaler plus oral Prednisone plus dose of azithromycin, an antibiotic, or would you settle for Salbutamol metered-dose inhaler alongside an ICS beclomethasone metered-dose inhaler, or would you settle for Salbutamol continuous nebulizer alongside beclomethasone and azithromycin, or would you settle for Salbutamol continuous nebulizer and oral Prednisone? I'll give you 10 seconds to choose the correct answer. So I would opt for Salbutamol metered-dose inhaler alongside oral Prednisone and azithromycin. Now, the GOLD guidelines recommend using Salbutamol inhaler versus continuous nebulizer in patients with chronic obstructive pulmonary disease exacerbations. However, There were no significant differences found between using an MDI or nebulizers as a means of salbutamol dose delivery. I would like to remind you that salbutamol is recommended as or to be inhaled at a dose of 1 puff every 1 hour for 2 to 3 doses, then every 2 to 4 hours based on the patient's response. Now, systemic glucocorticoids have been shown to shorten the recovery time and to improve lung function. They can also improve oxygenation. They can reduce the risk of early relapse in COPD exacerbations. Now, to be specific, prednisone 40 milligrams orally once daily for 5 days is the recommended dose in such exacerbations. And I would like to emphasize that patients with 3 cardinal symptoms, which are increased dyspnea, increased sputum volume, and increased sputum purulence, or those with 2, if increased sputum purulence is one of the 2, should receive antibiotic therapy for 5 to 7 days. Now, the agent used depends on local resistant patterns, but typically a macrolide, a tetracycline, or an amino penicillin co-formulated with clavulanic acid, or a beta-lactamase inhibitor combination will be used empirically. I would like to add that nebulized beclomethasone may be a viable alternative in certain patient populations, and it provides similar benefits to, for example, IV Methylprednisolone. Now, I would like to remind you that more than 80% of COPD exacerbations can be managed on an outpatient basis using a treatment approach that may include bronchodilator corticosteroid and antibiotic therapies like the one we have just listed above. Let's move to the next slide, please. And the question reads, Miss LBB, a 16-year-old Kenyan female patient, presents to your chest clinic with a past medical history significant for allergic rhinitis, which is managed with cetirizine taken at a dose of 10 milligrams orally once a day, and newly diagnosed asthma, for which she currently takes no medication. She's on no current therapy. The clinical team at your hospital wishes to initiate long-term therapy to control LBB's asthma. So my question to you is, which of the agents listed below would be the most effective and preferred therapy to initiate in Miss LBB's case today? Would it be Pharmacotherapy, fluticasone, chromonile sodium, or tiotropium? I'll give you 10 seconds to choose the correct answer. So fluticasone, it is an ICS. Now, the use of inhaled corticosteroids such as fluticasone, which is marketed as Flovent, is considered the preferred therapy for asthma, given the ability to effectively control the underlying issue of inflammation and the subsequent consequences of that inflammation. Now, chromonile sodium in the past used to be considered an alternative but not preferred or recommended therapy for mild asthma patients. And Pharmacotherapy, which is marketed as Foradil, shouldn't be considered as initial monotherapy given the safety concerns surrounding LABA products. There is a black box warning if you look at the literature inserts. And then tiotropium, which is marketed as Spiriva, is an anticholinergic agent and it isn't considered appropriate as first-line therapy in asthma, but it is appropriate in the case of chronic obstructive pulmonary disease. Let's move to the next slide, please. And the question reads, Mrs. P.L.O., a 27-year-old female, presents to your chest clinic for treatment of mild persistent asthma. She is in her 14th week of gestation. She is pregnant, and she was referred to the clinic for appropriate management. My question to you is, which of the medications listed below would be the most appropriate for Mrs. P.L.O. now? Would you choose to control her asthma with oral prednisone, with oral theophylline, with inhaled budesonide, or with inhaled salbutamol pro renata as needed? I'll give you 10 seconds to choose the correct answer. I would manage her asthma with inhaled budesonide. Now, for expectant or pregnant patients with mild persistent asthma, low-dose inhaled corticosteroids (ICSs) is recommended as the preferred treatment. I would like to emphasize that inhaled budesonide is a preferred inhaled corticosteroid for pregnant patients, since it has the most supporting data of safety and efficacy. Now, patients who are not adequately controlled with the low-dose inhaled corticosteroids can add a LABA to their treatment. Now, oral theophylline is safe in pregnancy. However, it is not preferred as first-line or second-line therapy. Now, oral corticosteroids should only be used if the patient is being treated or as part of the asthma action plan for an acute exacerbation. Now, remember, PLO doesn't have an antecedent acute exacerbation. I would like to emphasize that salbutamol pro renata monotherapy is no longer recommended as first line for the management of asthma according to the GINA guidelines. Now, the first line management of step 1 asthma begins with a PRN inhaled corticosteroid therapy. Now, while the use of salbutamol, montelukast, and theophylline aren't associated with increased fetal abnormalities when used for asthma in pregnancy, they are not considered first-line agents, so I would not go there, I would not use them. I would like to remind you that low-dosed inhaled corticosteroids are preferred for mild, persistent asthma cases in pregnancy, and they can reduce the incidences of asthma exacerbation in the course of the pregnancy during gestation. I would like to remind you that neonatal hypoglycemia has been associated with high-dose SABA therapy during labor. So be very, very cautious when managing asthmatic mothers around labor period. Now, for mothers who require high-dose SABA during the 48 hours leading up to delivery, they pose the highest risk of neonatal hypoglycemia. So be very, very cautious when managing pregnant mothers who are in labor or who are around the time of delivery that are asthmatic and that need intervention. So my highly esteemed viewers and listeners, that brings us to the end of this video. Now, if this video benefited you in any way, please remember to give it a thumbs up, to like it, and to share it widely with your peers. And if you haven't yet done so, I humbly urge you to subscribe to my YouTube channel. I would like to promise you that the best is yet to come. Thank you very much for viewing this video and for listening to me. I sincerely appreciate your partnership and your continued support and kind collaboration, and I look forward to interacting with you in part 63 of our Pharmacotherapy MCQ series. Thank you very much.